Hello, I'm Kylie Baker. I'm an emergency physician from a small suburban hospital in Australia. I'm in the odd position of giving a talk on how to scan for COVID without actually having seen one yet. But I think we're in the very sad position where the people who could really teach us the most are currently too busy just staying afloat. So, the only claim to fame I have is that I have been researching and teaching lung scanning for the last 10 years or so, and all I'm going to do is try and upskill or give you some quick tips about what I think you should be doing and looking for in COVID. I'll leave it to Josh and Adam to discuss when and where and why we should be scanning, or for that matter, if. Now, the whole thing we're looking for, you might remember, was this thing called the bat view that Liechtenstein coined many years back. We do it by slinging any sort of probe between two ribs. The ribs are what gives us the rib shadows, and the rib shadows are what points us to the pleural line, which is the bit that we focus all our attention on. Now, you can use just about any probe to scan the lungs, even a transvaginal, but be aware that the pictures are very different and they have different advantages. For example, a linear probe on the left is what we'd use for children. The curved abdominal probe in the middle is what we use for slightly deeper people. And the cardiac probe on the far right is what you might use in the really obese people. If you can try and get the videos going, you'll see that the linear probe is very good for looking at the pleural line itself. The curved abdominal probe gives us a wider view. You can still see the same B line there, but less clarity of the pleural line. And finally, with the cardiac probe set as shallow as I could, we see that B line nice and distinctly, but the pleural line is unfortunately always a little bit unclear. If the cardiac probe is all you've got, however, please think about using a standoff or, say, a 100ml bag of saline with some jelly on either side if you need to get a bit more depth between the probe and the pleural line. You probably heard about the heart failure conventions, the 8-view Valpicelli view where we look at 4 pictures, 2 at the front and 2 at the side. Now, this sort of protocol I don't think is going to help us much in COVID. So I think we need to take at this point a leaf out of the pediatrician's books and do the slide, and particularly because we're looking for localized patchy changes that are post-row and post-row-basal, we really should focus on the patient's back. And frankly, I think this is the safest way to approach the more mobile ones. So if we have patchy change, what we need to do is look down each space. I would suggest a slide down medial to the scapula, then up to the axilla. And then if you haven't seen anything on the first pass, try again in transverse and slip down each rib space. There are 2 challenges to lung scanning. That's a lot less than most point-of-care ultrasound. The most important one is that your beam is at right angles to the pleura. Now, the reason this is important is that you can, first instance, lose the pleura if it's not sharp and white like this. The picture on the left has a perfect angle to the pleura, and you can see that because we have the A pattern reverberating underneath, here and here and here. On the other side, however, we can barely see the pleural line, and that's in the first place because we haven't got the probe at right angles to the pleura. We need to fan it a little. But secondly, because the focus is also pretty deep. Now, the reason this will become particularly important in COVID is, as you can see on the left, we've got a really nice, thin, sharp pleural line with the lung curtain sliding up and down just over my right kidney. And on the right-hand side, we have a sort of indistinct rumpled sliding into what you'd almost wonder was a small pleural effusion, but in actual fact exactly the same probe position, and all I've done is fanned the probe a little bit. So you can fake it if you're not careful. That's why I think I want you to pay strict attention to the probe position. And for that reason, we'll have a very quick look at the shape the ribs actually curve. Now, it's fine on a skeleton. You can see the ribs very clearly. But when your patient is well padded, and we hear that the obese are the ones that suffer the most from COVID, it's important that you imagine in your mind the shape of the thoracic cage rather than following the skin contour. You've probably already come across this little tip when you're scanning anteriorly in the upper zone. You know not to point the probe directly back towards the bed, because at this point, mid-clavicular line, the ribs are already starting to curve laterally, meaning that you have to tilt the probe a little bit towards the mediastinum if you want to be at right angles to the pleura in the upper zone. If we look at the back, it's a lot more curvaceous. The back of the patient, you can see how the ribs dive to attach behind the transverse processes. Now, this sort of curve is actually padded out by the erector spinae muscles, and so we don't see it very clearly when we look at the patient. If you were by habit to scan straight towards the front of the patient, you're actually going to miss the pleura quite neatly. You have to, at the back, turn your probe away from the midline to see the pleura clearly. A couple more things are that the ribs aren't horizontal, they curve downwards. And if you have the probe slicing obliquely across the ribs, your picture will be a lot more indistinct and you get less expansive pleural line. By rotating the probe, or in this case the TV remote, so that you're 90 degrees to the direction of the ribs, you'll get clearer rib shadows and a greater expanse of pleural line. Now I'm recommending that you do a continuous sweep from the top to the bottom. But remember, as you sweep around towards the axilla, that the patient's thoracic cage is round. It's not a box. So every time you move even a few centimeters towards the axilla, you have to adjust your angle, pointing the beam back in towards the patient's midline. And if at any stage you find even the slightest B-line like this, I would recommend that you rotate the probe into the rib space and look for the other signs that we're told are typical of COVID. The thickened pleural line, the subpleural consolidations, and possibly even small subpleural effusions. I think it's important that we spend time scanning laterally. Anything to avoid the front and the aerosols. Also, we need to scan transversely down the lateral side because it'll be the best way we can have a peek underneath the scapula. If you have your patient sitting with their arms forward and crossed in front of them, you can move the wing of the scapula out of most of the way. Now here's just a couple of quick cases that were a few years back, but I'm putting them in because they're viral pneumonitis. One will show what it looks like in a child and one what it looks like in an adult. Starting with the normal, and I don't recommend that you start at the front, here is us sliding down the front of the child's chest. Kiddies usually have pristine pleural lines, these tiny little indiscretions in the pleural line we think are non-specific, and you can see we've got the cartilaginous ribs. This is what you expect to see fairly normally. Now if we go down the other side on the left, we have again the cartilaginous ribs, but on the screen left you can see we're just getting the beginning of some B lines locally dripping down off that last costal cartilage. If we slide down the sides of the patient, and it's easier to do in single sweeps in kiddies, although they do move, we can again see a thickened area or slightly irregular on the screen left under the ossified ribs. I'll slide down the left side now. Again, another very small pleural line defect with the sub-B line, the B line that comes underneath the defect. Posteriorly, I've cut this one short. At the apex of the right lung, posteriorly, there was this small area of consolidation with air bronchograms and a shred sign deep. On the left side, however, we have the far more typical signs of the viral pneumonitis, an area of dense B lines, pleural thickening here. Now think back to that x-ray. It was very non-specific. Let's have a look at it. Would you have picked a small right upper lobe consolidation from this x-ray and dense pleural line abnormalities in the left base paraspinally? Probably not. So I think our ultrasound can pick things up more quickly than the chest x-ray, and we hear possibly than the PCR. Here's the other end of the spectrum. This is an elderly patient, quite a bit larger, several days of fever, cough and mild breathlessness. Looking at the apices right and left with the curved abdominal probe, we can see already, this one's a bit bodgy, this picture, lots of B lines sliding freely, quite bright. This is what we see in the diffuse interstitial picture. The fact that they're right at the apices already is a little bit worrying. If you saw this everywhere, you'd be thinking heart failure, heart failure. When we look down the sides, it continues, but we notice that we're starting to have small pleural line consolidations here. And here on the left side, you can actually see the wrinkling of the pleura, where it's pulling off the parietal pleura here. And finally, down the bases, we have a fairly normal base, with the exception of all the B lines here on the right. And on the left, we have something very abnormal. Now, I had to look at this several times to try and decide whether this was actually stomach or lung collapse consolidation. It was round posteriorly. I'm pretty sure it was consolidation, but be very wary of stomach masquerading as pneumonia or consolidation. Go back and forth over the diaphragm to be sure in your mind where it is. With the elderly patients particularly, I think we'll be encouraged to look at the heart and the IVC to try and work out if we're getting in any of the cardiovascular problems. Now, this patient that I've just shown you was diagnosed clinically and with the lab tests as having an RSV pneumonitis. So let's briefly recap the signs that you're looking for. And remember, it's not just the individual signs, but it's the pattern of the patterns. In other words, we're looking for patchy, discontinuous initially, signs that are bilateral, symmetrical, and predominantly posterobasal. First of all, we're looking for localized B lines, and if you see these, stop and look closely in this area. If they're thick and confluent like this, we're getting more worried. Look for areas of subpleural consolidation. There's just a whisker of that on the right of the screen. With a straight probe, you might see very small subpleural consolidations. You'll miss them if you don't keep your eye on the ball, on the screen, I should say. With the straight probe, you can see patchy irregularities, little consolidation at the left. With the curved probe, it will be less clear, but you'll see a lot of a wider picture. Some of the papers are talking about localized subpleural effusions. I've seen these a bit in the past. I think this may be what it looks like. However, I can't swear it. This is another one which could have been a localized subpleural collection or could have been an asbestos plaque. I'm not sure which it was. Finally, looking at consolidation, this is consolidation with a straight probe. You can even see the dynamic air bronchograms. Here is consolidation with a curved probe, more dynamic air bronchograms, the irregular shred sign at the bottom, which is your aerated lung. And finally, you can still see consolidation with a phased array cardiac probe. You can see a lovely spine sign continuing posteriorly right up into the chest. the things that I can say so far off a couple of the papers that have been coming is that pleural effusions are thought to be uncommon. Unilateral disease is uncommon and points a little bit more towards bacterial change. And as He Huang has said, that there seems to be a relative ischemia of these subpleural lesions. Anyway, I love the chance to get on my soapbox and teach. I hope this is some use to you. Remember, it's up to you to decide when and why to scan. And this is just a quick recap on how. Thank you.